Hello. Today we will cover the objectives for week 1. This presentation is in two parts, part A and part B. This is part B. Chapter 4 is physical assessment. You will be tested on this chapter as well as the media presentation screened in clinical. So an important part of physical assessment is establishing a setting for communication. You want to introduce yourself, establish parental roles, ask how to address the parents, ensure privacy and confidentiality, encourage talking, use open-ended questions, direct the focus, listen and observe with cultural awareness, use silence and empathy to avoid communication blocks, provide anticipatory guidance, consider the need for a professional interpreter. If you need a professional interpreter, here are some guidelines. Explain to the interpreter the reason for the interview and the type of questions that will be asked. Clarify whether a detailed or brief answer is required and whether the translated response can be general or literal. Introduce the interpreter to the family and allow some time before the interview for them to become acquainted. Communicate directly with the family members when asking questions to reinforce interest in them and to observe nonverbal expression, but do not ignore the interpreter. Pose questions to elicit only one answer at a time, like, do you have pain? Instead of, do you have pain, tiredness, or loss of appetite? Refrain from interrupting, family members and the interpreter while they are conversing. Avoid commenting to the interpreter about family members because they may understand some English. Be aware that some medical words such as allergy may have no similar word in another language, so try to avoid medical jargon whenever possible. Be aware that cultural differences may exist regarding views on puberty, sex, marriage, or pregnancy. Allow time after the interview for the interpreter to share something that he or she thought could not be said earlier. Ask about the interpreter's impression of nonverbal clues to communication and family members' reliability or ease in revealing information. Arrange for the family to speak with the same interpreter on subsequent visits whenever possible. What are some blocks to communication? Barriers include socializing, giving advice, offering false reassurance, giving over encouragement, giving opinions, using stereotypes, using complex medical language, close-ended questions, asking leading questions that suggest only a correct answer, interrupting or finishing the person's sentences, talking more than the interviewee, forming prejudged conclusions, and deliberately changing the subject. Signs of information overload for the patient. Here you might see long periods of silence, wide eyes and fixed facial expressions, constant fidgeting or attempting to move away, nervous habits like tapping or playing with the hair, sudden interruptions like asking to go to the bathroom, looking around, yawning, eyes drooping, looking at a watch or clock, or attempting to change the topic of discussion. It is important to encourage the parents to talk. Interviewing parents not only offers the opportunity to determine the child's health and developmental status, but also offers information about factors that influence the child's life. Whatever the parent sees as a problem should be a concern to the nurse. Do not exclude the child during the interview. Communicating with children. Make communication developmentally appropriate. Get on the child's eye level, approach the child gently and quietly while involving the parent or caregiver. Always be truthful. Give the child choices as appropriate and include play whenever possible. Nursing care guidelines, communicating with children. Allow children time to feel comfortable. Avoid sudden or rapid advances, broad smiles, extended eye contact, and other gestures that might be seen as threatening. Talk to the parent if the child is initially shy. Communicate through transition objects like a doll, a puppet, or a stuffed animal before questioning a young child directly. Give older children the opportunity to talk without the parents present. Assume a position that is at eye level with the child. Speak in a quiet, unhurried, and confident voice. Speak clearly, be specific, and use simple words and short sentences. State directions and suggestions positively, telling them what you want them to do versus what you don't want them to do. Offer a choice only when one exists. Be honest with children. Allow children to express their concerns and fears, and use a variety of communication techniques. So, how are you going to communicate with an adolescent? Here, you want to build a foundation by spending time with them. You want to encourage expression of ideas and feelings, respect their views, and tolerate differences. Praise good points, also respect their privacy. You want to set a good example. You want to give them undivided attention and listen. Be courteous, calm, honest, and open-minded. Try not to overreact. If you find yourself overreacting, you might want to just take a little bit of a break. Avoid judging or criticizing. Also avoid giving the third degree by continuously questioning them. Choose important issues for when you need to take a stand. And then after taking the stand, you want to think through all of the options and make the expectations clear. Play. This is the universal language of children. It's one of the most important forms of communication and can be an effective technique in relating to them. Box 4-3 in your text has creative communication techniques with children. They're divided into verbal and nonverbal. I'm going to highlight a couple. I'm not going to read the whole table to you. So verbal techniques include using I messages instead of you messages, using third person technique, using a facilitated response, meaning that you make the statement, you feel this because, and you let them fill in the blank, using storytelling as well as mutual storytelling, using bibliotherapy, meaning that you're using books in a therapeutic and supportive process, dreams, asking what if questions and seeing what their responses are, asking them the 3 wishes, if they could have 3 things in the world, what would they be? Using the rating game. So this is where you can use numbers or happy and sad faces, and you can have the child rate an event or feeling. So you can ask them, how is their day going? On a scale of 1 is just horrible, and 10 is it's an excellent day. You can also use word association. So you can say a word and have them say the first word that pops into their head. Sentence completion. So here you can say something like, the thing that I like best about school is, and then they can complete that. Doing a pro-con list. Here you can select a topic, and then you can have them write 5 good things about whatever that topic is, and then 5 maybe negative things about that topic. Nonverbal techniques, basically the child that you're working with is not talking. So somebody else could be, but the child is not. So here you can do things like writing in a journal or writing a letter that they're not necessarily going to mail, drawing. At times they might actually evaluate the drawings. They can use magic because this can actually help to provide distraction. And then again, play. This is the universal language and work of children. It tells a great deal about them because often they will project their inner selves through the activity. Spontaneous play involves giving the child a variety of play materials and providing the opportunity to play. Directed play involves a more specific direction, such as providing medical equipment or a dollhouse for focused reasons, such as exploring the child's fears of injections or exploring family relationships. So let's talk a little bit more about the history and the physical. We've already just addressed the developing the rapport part. So history taking, obviously we're going to do the chief complaint, history of present illness, family history, and then the interval history. We want to talk about their diet, any previous illness, injury, or operations, allergies, medications, immunizations, and growth and development. General approaches to examining a child. In general, you're going to want to do whatever needs a quiet child first. So you may not be doing that typical head-to-toe assessment that you normally do with an adult. You want to use communication techniques, play, and parental assistance to complete the examination. The goals of the assessment is to minimize the stress and anxiety associated with the assessment of different body parts, foster a trusting nurse-child-parent relationship, allow for maximum preparation of the child, preserve the security of the parent-child relationship, and then maximize the accuracy of assessment findings. So when you're doing the physical exam, growth measurements, you can do height in two ways. Length is actually when they're lying down. So think length lying down. Height is when they are standing up. So typically from birth to, depending on the type of chart you are using, you can go up to 36 months with a recumbent length. And then also you will be doing the weight and head circumference. If you're doing a standing height, that's something that you can do starting at 2 years of age. Then you would also do a body mass index after 3 years of age. You can plot on a growth chart, and typically you're also going to note gender and prematurity. Values less than 5th percentile or more than the 95th percentile are considered outside of the expected parameters for height, weight, and head circumference. And you're welcome to go to the cdc.gov growth charts site to take a peek at those charts. And they are also in the back of your book. So growth measurements during the physical exam focus on the length, height, weight, skin fold thickness, and arm and head circumference. Assessment of growth is measured against a standard growth chart to determine a child's status in comparison with other children of the same age. So if you are using the length chart from birth to 36 months, then the child must be measured lying down. If you are using the height chart, that can be used from 2 years to 20 years of age. That is with them measured standing up beginning at 24 months of age. The nurse may use a measuring board device, or they can even mark the table paper at the crown of the head and then straightening the legs at the bottom of the feet. Note that the legs must be fully extended and flat against the table. In older children, height is measured with the child standing upright with the shoes off, standing tall and straight as possible. The nurse might use a stadiometer. Head circumference is measured up to 36 months using a paper tape. In order to obtain a correct measurement of the head circumference, measurements must be made above the eyebrows and above the ear pinna to the occiput. Weight, birth to 36 months, you want to weigh them nude. Balance the scale first to zero it out, and then you want to weigh them in a comfortable, warm room with privacy. Physiologic measurements like key elements, like your vital signs, would include your temperature, pulse, respirations, and blood pressure. It's best to take vital signs of an infant and a small child, counting the respiration first. You don't want them disturbed. Then you will take the pulse and then the blood pressure, doing the temperature last. If the vital signs can't be taken without disturbing the child, you want to record the child's behavior, that is, like if they're crying, along with the measurement. Oral thermometers are not used until after about 4 to 5 years of age. Note that a rectal temperature is about 1 degree higher and an axillary temperature is about 1 degree lower than the oral. Respiratory rate decreases with age. Infants are diaphragmatic breathers. You want to count for a full minute. It's not uncommon for their breathing to be a little bit irregular. And note that infants are obligatory nose breathers. The heart rate decreases with age. Again, you want to take that for 1 full minute, apically until they are 2. Once they are 2, you can do a radial pulse. The blood pressure increases with age. Blood pressure varies with the cuff width. Too large of a cuff, you will have a lower blood pressure. Too narrow of a cuff, you will have a falsely increased blood pressure. The bladder width should be 40% of the arm circumference, and the bladder should cover 80 to 100% of the arm circumference. So physical assessment. The general appearance of a child is a cumulative subjective impression of the physical appearance, state of nutrition, behavior, personality, interactions with parents and nurse, posture, development, and speech. So in general, what are we looking at? The general appearance, which includes their nutrition, behavior, personality, interactions with others, posture, development, and speech. You want to look at skin, hair, nails, hygiene, lymph nodes, head, neck, eyes, ears, nose, and throat, chest, heart sounds, lung sounds. Remember, the order in general is inspection, palpation, percussion, and auscultation, with the exception of the abdomen. Remember, the abdomen order is inspection, then auscultation, and then palpation. Okay, and percussion. We also examine the genitals, the back extremities. We want to look at the posture and positioning, their mobility, gait, strength, and symmetry. We want to do a neurologic assessment, and we also want to do an assessment of their balance and coordination, reflexes, and checking their cranial nerves. Again, there is a presentation that you will see in the skills lab that thoroughly covers this assessment, which you will also be tested on. Next, we will cover Chapter 9, which is the growth and development during infancy. Much of what I'm going to talk about right now is in a table in that chapter. So, age 1 month. We've already talked a little bit about this. Here, physically, they are going to gain 5 to 7 ounces a week, or 1.25 to 1.5 pounds a month for the first 6 months. Height gain of about 1 inch a month for the first 6 months. Head circumference increases by about 1/2 inch a month for the first 6 months. And as I mentioned, they are obligatory nose breathers. Gross motor. So here they can turn their head from side to side when prone, and they can lift their head momentarily from the bed. They do assume a flexed position. They do something called fencing position, or asymmetric tonic neck reflex when they are supine. When they are in a sitting position, the back is uniformly rounded and they do not have head control. Fine motor, the hand is predominantly closed with a strong reflex that is a grasping reflex. Sensory motor, they're able to fixate on moving objects in a range of 45 degrees when held at a distance of 8 to 10 inches. Visual acuity is about 2100. Typically, they will quiet when they hear a voice. In terms of vocalizations, they will cry when they're unhappy. They'll make small throaty noises, and they'll make comforting sounds when they are feeding. With socialization, here they will watch the parent's face intently as he or she talks to the infant. 2 months of age, physical, the posterior fontanelle is closed. Gross motor, here they have a little bit less head lag when they are pulled to a sitting position. When they are prone, they can lift their head almost 45 degrees off the table. When they are held in that sitting position, the head might be held up, but it will bob forward. Fine motor, the hands often open and that grasp reflex is starting to fade. Sensory, binocular fixation and convergence to near objects is beginning. They turn their head to the side when a sound is made at ear level. Vocalizations, here they have vocalizations that are distinct from crying. Crying becomes differentiated. They coo and they vocalize to familiar voices. Socialization cognition, here they are demonstrating a social smile in response to various stimuli. Age 3 months, here physical, the primitive reflexes are fading. Gross motor, they're able to hold their head more erect when sitting, but it will still bob forward. They're able to raise their head and shoulders from a prone position to a 45 to 90 degree angle from a table. They will bear weight on their forearms, and they regard their own hand. Fine motor, here they will actively hold a rattle, but they will not reach for it. The grasp reflex is absent. They will clutch their own hand and pull at blankets and clothing. Sensory, they follow an object to the periphery to 180 degrees. They will locate sound by turning their head to the side and look in the same direction. Vocalizations, here they will squeal aloud to show pleasure. They coo, babble, and chuckle. They cry less during periods of wakefulness. And socialization cognition, they typically will stop crying when a parent enters the room, and they can actually start to recognize familiar faces and objects such as a feeding bottle, and they're starting to show awareness of strange situations. Age 4 months, physical, drooling will begin. Typically tonic neck and rooting reflexes have disappeared. Gross motor, they have almost no head leg when pulled to a sitting position. Their back is less rounded and only curved in the lumbar area. They're able to sit erect if propped up. They're able to raise their head and chest off a surface to angle of 90 degrees. And the big thing here is that they can roll from their back to their side. Fine motor. Here they will grasp objects with both hands. They will play with a rattle placed in their hand and shake it, but they can't pick it up if it's dropped. And they will carry objects to their mouth. Sensory, they're able to accommodate to near objects. Binocular vision is fairly well established. They can focus on a half-inch block, and they're beginning to develop that eye-hand coordination. Vocalizations, they make consonant sounds like N, K, G, P, B. They laugh out loud, and their vocalizations will change according to their mood. Socialization cognition, they are in that stage 3 of secondary circular reactions, which we talked about in presentation A. They enjoy interaction with people. They anticipate feeding when they see a bottle or mother if breastfeeding. They show excitement with their whole body. They will squeal and breathe heavily. They show interest in strange stimuli, and they are beginning to show memory. Age 5 months. Here, birth weight doubles. They are showing signs of tooth eruption. Gross motor. There should be no head leg when they are pulled to a sitting position. That is a very, very important developmental milestone. When they are sitting, they should be able to hold their head erect and steady. They can turn over from their abdomen to their back. Fine motor, they are able to grasp objects voluntarily. They will take objects directly to their mouth. They will hold a cube while regarding a second one. Sensory, here they can localize sounds made below the ear. Vocalizations, here they are squealing and they're making vowel cooing sounds interspersed with consonant sounds like ah, goo. Socialization cognition, here they will smile at a mirror image. They will pat the bottle or breast with both hands. They're very enthusiastic in their play, but they do have rapid mood swings as well. They're able to discriminate strangers from family members. And they're discovering parts of their body. 6 months. Here, physical growth rate is starting to decline a little bit. The weight gain is now 3 to 5 ounces a week for the next 6 months. The height gain is about a ½ an inch a month for the next 6 months. Teething may begin with the eruption of the 2 lower central incisors, and so you might see biting and chewing. Gross motor. Here they can sit in a high chair with their back straight. They will roll from their back to their abdomen. Fine motor, they will resecure a dropped object. They can hold their bottle. They'll grasp their feet and pull them to their mouth. Sensory, here they can adjust posture to see an object. They can localize sounds made above the ear. They'll turn their head to the side and then look up or down. Vocalizations, they begin to imitate sounds. Babbling resembles one-syllable utterances like ma, mu, da, di, hi. They take pleasure in hearing their own sounds, so this is like a self-reinforcement. Socialization and cognition, here they recognize parents and they're beginning to fear strangers. They'll hold their arms out to be picked up. They have definite likes and dislikes. They will start to imitate. They like hearing footsteps because they know somebody's coming. They will briefly search for a dropped object. So they're beginning that object permanence. Okay, that's usually established by 10 months though. They do have frequent mood swings from crying to laughing with little or no provocation. Age 7 months, here physical, eruption of the upper central incisors. Gross motor, when they're supine, they'll spontaneously lift their head off the table. They can sit leaning forward on both hands. They can sit in a high chair with a straight back. They should be able to crawl. The abdomen is on the floor when they crawl. When they're held in a standing position, they can bear almost all of their weight. Fine motor, here they can transfer objects from one hand to another. They can hold 2 cubes more than momentarily. They will rake at small objects. Sensory, they can fixate on very small objects. They will respond to their own name, and they're beginning to develop those taste preferences. Vocalization, they're now doing vowel sounds and chained syllables like ba, ba, da, da, ka, ka. They can vocalize 4 distinct vowel sounds. And when other people are talking, they will also vocalize. Socialization and cognition, there's an increase in the fear of strangers, and they tend to be very fretful when their parents disappear. They will imitate simple acts and noises. They try to attract attention by coughing or snorting. They like to play peekaboo. They will demonstrate that they don't like something by keeping their mouth closed in terms of taste. They exhibit oral aggressiveness and biting and mouthing. At 8 months here, they're beginning to show regular patterns in bowel and bladder elimination. And the parachute reflex appears. And this is the reflex of when you're about to fall, your hands go up. It's a protective reflex. Gross motor, here they can sit steadily unsupported. Fine motor, they can ring a bell purposefully. They can retain 2 cubes while regarding a third. They will reach persistently for toys that are out of their reach. Vocalizations, they're making consonant sounds of T, D, and W. They're listening selectively to familiar words. They are combining syllables, but they don't ascribe meaning to them quite yet. And socialization and cognition, they respond to the word no. They don't stop their behavior, but they notice when you say the word no, it's like, hey, I know that word. They do dislike dressing and diaper changing. At 9 months, physical eruption of upper lateral incisors may begin. Gross motor, they may be creeping on hands and knees. The abdomen for creeping is off of the floor. They can sit steadily on the floor for a prolonged time, about 10 minutes. They can pull themselves to a standing position and stands holding onto furniture. There may be a preference of use of a dominant hand now that might be evident. Sensory, you want to localize sounds by turning head diagonally and directly toward the sound. Here they comprehend for vocalizations the word no or no, no. Socialization, the parent is very important. They want to please their parents. And you'll see that they're starting to show fear of going to bed or being left alone. They will put their arms in front of their face to avoid having it washed. Age 10 months, here they have the labyrinth, which is the writing reflex is strongest. And this is when the infant is in a prone or supine position, they're able to raise their head. Gross motor, here they can recover their balance easily while sitting. They can stand while holding onto furniture. They'll sit by falling. Fine motor, they have a crude release of an object beginning, and they can grasp a bell by a handle. Vocalizations, here's where they're saying mama and dada with meaning. They may understand by, and they may say one other word like hi, bye, no. This is also where at 10 months, where if you say the word no or their name in that tone, now they will inhibit the behavior. We already mentioned that at 10 months, they develop object permanence. They will repeat actions that attract attention and cause laughter. They pull clothes of another to attract attention. They will play interactive games like patty cake. They do react to adult anger and cries when they're scolded. They look at and follow pictures in a book. 11 months, here physical, they're going to have the eruption of lower lateral incisors. Gross motor, when they're sitting, they'll pivot to reach towards the back to pick up an object. Here they can cruise or they'll walk while holding onto furniture or with both hands held. They'll explore objects more thoroughly with fine motor, like a clapper inside of a bell. This is where they have that neat, what we call a neat pincher grasp. So where the index finger and the thumb meet. So it's 11 months where they develop this. It's called a neat pincher grasp. They're able to manipulate an object to remove it from a tight-fitting enclosure. Vocalizations, here they're imitating definite speech sounds. Socialization and cognition, here they experience joy and satisfaction when a task is mastered. They will roll ball to another on request. They will anticipate body gestures when a familiar nursery rhyme or story is being told. Like this little piggy went to the market, so they know when you're going to do the, this little piggy went to the market, this little piggy went home, and when you're about to tickle them, they anticipate that. They like to play games up and down, or it's so big, or peekaboo, and they will shake their head for no. At 12 months, here, physical birth weight is tripled. Birth length is increased by 50%. This is where the head and chest circumference is equal. Usually prior to 12 months, the head is bigger than the chest circumference. After 24 months, the chest circumference is bigger than the head. Here they have a total of 6 to 8 teeth. The anterior fontanelle is almost closed. Usually the anterior fontanelle closes anywhere between 12 and 18 months. And also here, this is typically when the Babinski reflex disappears. Gross motor, they should be able to walk well with one hand well. Typically they will cruise well, meaning that they're walking while they're holding onto the furniture. They may attempt their first step alone. Fine motor, they'll release a cube in a cup. They will try to build a 2-block tower, but they fail. They can turn pages, lots of pages in a book at a time. Sensory, amblyopia may develop if they lack binocularity. Here they can control and adjust response to sound, and they listen for sound to reoccur. Vocalizations, here they say 3 to 5 words besides dada and mama. Please remember that understanding words comes before verbalizations. So they can understand a lot of what you're saying, but they just can't verbalize it. They do recognize objects by name, and they can even understand a few simple commands like give it to me or show me your eyes. Socialization, cognition. Here, they can show emotions such as jealousy and affection. They are fearful in strange situations and they'll cling to the parent. They may develop a security blanket or a favorite toy. This also can be referred to as a transitional object. So now let's talk a little bit about injury prevention during infancy. So these topics are really developed or occur because of their developmental accomplishments. So what they are able to do developmentally will increase their risk for certain problems or certain risks for injury. So the developmental accomplishments from birth to 4 months, here basically, remember they could roll maybe a little bit at 4 months from their back to their side. They have an increasing eye-hand coordination and voluntary grasp. So what kinds of injury prevention things do we need to think about? So aspiration, that's not really that great of a danger in this age group, but you want to, be practicing safety early, and keep this in your head, because when we're going to 4 to 7 months, when we start feeding them, you want to just kind of think about this. But baby powder, please don't shake that on them directly. If you're going to use baby powder, put it in your hand first. We don't want them inhaling that. When you're feeding an infant, you want to hold them upright. You don't want to prop a bottle. You do want to know the emergency procedure for choking. And if you're using a pacifier, you want to use one that has a one-piece construction and a loop handle. You want to keep all plastic bags stored out of the infant's reach. Discard large plastic garment bags after tying in a knot. Do not cover mattresses in plastic. You want to use a firm mattress with an absorbent pad under the sheet. Use a firm mattress. Really, it's ideally no blankets, no pillows. There should be nothing inside of infant's bed because of SIDS. If you feel like you have to put a blanket on the child, you want their feet at the bottom of the crib, and then a very thin blanket no higher than their waist. Cribs do have to meet certain federal regulations. The crib slats should be less than 6 centimeters apart, or no wider than 2.2 inches and 2 3/8 inches. The crib should be away from other furniture and from radiators. Please do not tie a pacifier on a string or tie something around a child's neck. If they have a bib on, please make sure that you take that off at bedtime. You do not ever want to leave anything around the child's neck if you are not with them. Never leave an infant alone in a bath. And then don't leave an infant under 12 months of age on anything that's elevated. So like on a mattress, or if you're on a changing table or anything like that, because you don't want them to fall off. Falls. So keeping the crib rails up, right? We don't want to leave an infant on any kind of a raised surface. So the safest place for a child, really, if you are in doubt, is on the floor. You want to restrain the child in an infant seat. Never leave them unattended anytime they're on a surface that is not the floor. If you are if they are using a high chair, make sure that they are secured in it. They have these secure belts that you can put them on so that they don't slip out. And you want to avoid using a high chair until a child can sit well with support. Poisoning. So here again, really not a big issue from under 4 months of age, but again, just thinking about these safeguards early is not a bad idea. Burns. This is something that you're going to do not just for this age range, but for mostly everybody. Smoke detectors in the home. We strongly discourage warming formula in the microwave because it can have hot spots. So you really don't want to do that. Heating it in the bottle, in water on the stove is much better. And then you want to check the temperature of the liquid before feeding the child. Checking the bath water, you don't want to burn them. Don't pour any kind of hot liquids when the infant is close by, like if they're sitting on your lap. You should never be smoking anywhere around an infant, or even in the house if there is an infant there. But if somebody is doing something like that, they shouldn't be smoking with an infant on their lap, because the hot ashes can fall on them and burn them. You don't want to leave an infant in the sun for more than a few minutes. After 6 months, you can put sunscreen on them. Prior to that, you need to keep them covered. Make sure they have flame retardant clothing, that they are washed according to the label. If they have a respiratory problem and they need a cool vaporizer, you're going to use a cool mist vaporizer, because that's much safer. Never, ever, ever leave a child in a parked car. Super important. And then when you're putting a child in a car seat, you want to check the surface to make sure it's not hot before you put them in the car seat, because the belts can be hot and they can burn them. Motor vehicles, you want to transport infants in federally approved rear-facing car seats, and they need to be in the back seat. They cannot be in the front seat. You don't want the child in your lap. That is super, super dangerous. Do not place a child in a carriage or a stroller behind a parked car, and don't place an infant or a child in a front passenger seat with an airbag. Bodily damage, here you want to avoid sharp, jagged objects. If you are using cloth diapers that require pins, you want to keep the diaper pins closed and away from the infant. Age 4 to 7 months. Here the milestones are that they can roll over, they can sit momentarily, they can secure dropped objects. Mouthing is very important. So this is where aspiration becomes an issue. You want to keep anything small out of their reach. You want to keep the floor free of any kind of small objects. Don't feed an infant anything that like hard candy, nuts, foods with pits in it, circular pieces like a hot dog. Anything that you're going to give them, it needs to be something that's small and cut in irregular shapes. Do not feed an infant while they are lying down. You want to inspect toys for any kind of removable parts. You want to avoid storing, any kind of pesticides or toxic substances. Do not store toxic substances in food containers. You want to store batteries in a safe area. Very important to know the Poison Control Center. Suffocation. You do not want these children to have latex balloons because when they pop, they can choke on the pieces and then it's very hard to get out. You want to remove any kind of crib toys that are strung across the crib or playpen when they start to push up on their hands or knees or when they're 5 months old. Falls, again, restraining them when they're in the high chair, keeping the rails up the full height. Poisoning, here you just want to make sure that their toys don't contain any kind of lead paint or any surfaces contain any lead paint. Make sure also any plants that are, potentially toxic, really you don't want them anywhere the child can get to them. Burns, keep faucets out of reach. You want to place anything that's hot on a high surface. And then, as I said before, you want to apply sunscreen, once they're 6 months and older. And really, you still want to protect them from the sun. Bodily injury, you want to give toys that are smooth and rounded. Avoid anything that's pointy. Also avoid anything that is loud. So 8 to 12 months here, they can crawl and creep. They can hold onto furniture. They can throw objects. They have that neat pincher grasp. They can put things in their mouth. So again, aspiration is just keeping anything small off of the floor and out of their reach. Making sure that when you're feeding them that you've got the pieces cut into very small pieces. You don't want to give them any kinds of toys that have like little beans inside of them, like beanbag toys or anything like that. Suffocation and drowning. Here you want to keep doors or ovens, dishwashers and refrigerators or coolers. You want to keep them closed at all times. If you have like a refrigerator or something that you're not using anymore, take the door off because you don't want them to get locked inside and suffocate. If you've got balloons around, ideally you use the Mylar balloons. And once it's popped, you want to throw it away and make sure that it stays away from them because you don't want them to choke on it. Swimming pools need to be fenced because we don't want them to drown. It's very important to keep anything with water. Make sure that the child is always supervised anytime there's water. You want to keep the bathroom doors closed and really just eliminate any kind of unnecessary pools of water. Anytime the child is in the bathtub, you should keep a hand on the child at all times. Falls, here, you want, if there's a stairway, you want to have a a fence at the top of the stairs as well as at the bottom of the stairs, because again, we don't want them falling down the stairs. You want to dress the infant in safe clothing. So the pants should not be too long. If they have shoelaces, they should be tied. Walkers are not going to make the child walk faster, so we actually strongly recommend not using walkers, especially around stairs. The other thing is that the walkers can put them in a higher position where they can pull things down onto them. Poisoning, you want to administer medication as medication, not as candy. You don't want to give medication unless it's prescribed. And then really, you want to make sure also that you have caps that are properly secure, that are child protective caps. Burns, so just making sure that there are guards in front of anything that is hot, like a heating appliance, fireplace, or furnace. Keeping electrical wires out of reach. Placing plastic guards over electrical outlets. And you can put furniture in front of outlets. And then keeping hanging tablecloths out of the reach of a child, because again, we don't want them pulling down the tablecloth and then hot liquid falling onto them. As you can see, the type of injury is really determined by the child's development. And I mentioned this before, leading cause of death is for unintentional injuries. We talked about motor vehicle accidents when they're over a year of age, but suffocation is very important for infants. And this is why we put them on their backs to sleep. We call that the Back to Sleep Initiative. And when we talk about SIDS, we will talk about that again. But know that all infants should be placed on their backs when they go to sleep. Car seat safety. So here, just a little bit about car seat safety. Some of this is not in your textbook, but that's okay. It's important to know. Car seats do expire. They have a life expectancy of about 6 to 7 years. You don't want to get them from a secondhand store or garage sale because you don't know if they've been in a car accident. If a car seat is in an accident and it was empty, it's still good. If somebody was in it, you need to throw it away. Do not remove material off car seats. You want to wipe them with a damp towel. Removal damages the integrity of the car seat. Place the car seat directly on the car seat. You don't want to place a towel or a blanket under it. Place this car seat restraint belts over thin clothing so the restraint clip or the chest clip is close to the skin. Place blankets or thick jackets over the restraining belts. The chest clip should be at the axilla level. If it is not, you can actually get a ticket. Rear-facing infant seats must be placed at a 45-degree angle to prevent airway obstruction. Children under 2 must be in a rear-facing seat unless they are 40 or more pounds or are 40 or more inches tall. You want to keep a child in a car seat as long as the manufacturer allows by weight. Booster seats until they're 8 years old or they are 4'9". They may sit in the front at age 8 legally, but it is safest to wait until they are 13 to sit in the front seat, especially if they have airbags. A little bit about growth and development. This is just sort of a general summary. We've already talked about all of this. The physical growth, birth weight doubles by 5 months, triples by a year, quadruples by 2.5 years. Height, 0 to 6 months, increases by 1 inch per month. 6 to 12 months, increases by 1/2 inch per month. Birth length increases by 50% at a year of age, then doubles by 4 years of age. And a child is half of their adult height at 2 years of age. During the first 6 months of life, fetal hemoglobin is replaced by adult hemoglobin. So it's after this that if they have hemoglobinopathies, that's typically when they're going to see signs and symptoms if it was not diagnosed prior to that. Usually one gives oral iron or formula with iron or iron fortified cereal between 4 and 6 months of age. They crawl at about 7 to 8 months-ish. We've already mentioned it was 7 months. And they creep at about 9 months of age, and that's the one where the abdomen is off the floor. The rib cage is very flexible, so if they have respiratory distress, you will see retractions. The smaller diameter of the airway increases any risk to obstruct the airway. They are more barrel-chested as infants and rely on diaphragmatic breathing. And then abdominal breathing till they're about age 5. This progresses to the thoracic breathing as they become adults. And then abdominal distension can actually impede breathing for infants. A short eustachian tube, as the eustachian tube is actually close to the ear. This can increase issues with infection from the pharynx to the middle ear, so then they have more problems with middle ear infections. A majority of the digestive processes are immature or don't really function at birth and begin functioning at 3 months of age. The liver has immature functioning for the first year of life. The increase in adipose tissue during the first 6 months of life insulates the body against heat loss. Renal structures are fully mature at the 2nd year of life, and tears develop at about 2 to 3 months of age. At 4 months, drooling begins as a part of the teething process. Teething begins about 5 months. So here you're going to see drooling prior to, as I mentioned, you're going to see finger sucking, biting on hard objects. They might be irritable. They might not be sleeping well. They may refuse to eat. The lower central incisors are followed by upper central incisors when they come out. So nursing management, they can have some pain due to inflammation. You can give them like a cold or frozen teething ring with supervision. Be careful with the frozen teething rings because you don't want to freeze their gums. Okay, so you can, ideally it's cold, frozen, you can do it a little bit and then take it off to prevent freezer burn. You can also use an ice cube wrapped in a washcloth, like a really good secure washcloth, because you don't want them to choke on the ice cube. They have baby Oragel, baby Tylenol, and baby Motrin. So there is a formula for the number of teeth a baby should have. Basically, it is their age in months minus 6 is the number of teeth that they will have. So if they are 12 months of age, 12 minus 6, they should have about 6 teeth. And if you'll recall, your text said they have anywhere from 6 to 8 teeth. Fluoride, 0.25 milligrams may be started at the 6th month of age, and usually through 3 years of age if the water fluoride level is less than 0.3 parts per million, or if the child is only breastfed or they only drink unfluoridated bottled water. Fluoridated bottled water is available for formula mixing and drinking for children. Infants should have a brief oral health examination by 6 months of age from a qualified health practitioner and have an established dentist by the time they are 1 year of age. Play during infancy. So from birth to 6 months, visual experiences for play would include nursery mobiles, unbreakable mirrors, see-through crib bumpers, contrasting colored sheets. Auditory would be music boxes, musical mobiles, crib dangling bells, rattles. Tactile would be stuffed animals, soft cloths, furry quilts, soft mobiles. And then kinetic would be things like a rocking crib cradle, a suction toy, or infant swing. 6 to 12 months visual, here you could see large colored blocks, nesting box or cups, books with rhymes and bright pictures, simple take apart toys, jack in the boxes, cups and spoons, large puzzles. Auditory, they can have rattles of different sizes, bright colors, squeaky animals and dolls, light rhythmic music. Tactile, here's different textured animals or dolls, sponge toys, floating toys. They can have teething toys, books that have texture like fur or zippers. And then they can even have for kinetic, like an activity box for their crib, push-pull toys, and a wind-up swing. Breastfeeding versus bottle feeding. We all know breastfeeding is best. It is perfectly fit nutritionally for an infant. It increases their immunity. It passes immunoglobulins to the infant via the breast milk for the first 4 months. It promotes bonding. They are less colicky. You can typically refrigerate it up to 8 days and freeze for a year. The only problem with breastfeeding is initially you need to feed them every couple of hours, and you can't necessarily measure the exact amount they eat unless you're pumping it and measuring it in a bottle. But as long as they have a sufficient number of wet diapers, we know they're okay. Bottle feeding. Here, you know exactly how much they are eating and they are fed less often. The problem is that they can have issues with allergies. They have more colic. It's expensive. You've got to buy everything like the formula, the bottles, the nipples. Just kind of FYI, after you feed the baby, if they're awake, they can be positioned on their right side to facilitate digestion. If a child is asleep, remember, we always put them on their backs to sleep. FYI, you only give water or a pacifier when you're putting an infant to sleep. Do not give sugar water or juices in a bottle due to tooth decay. This is also called bottle mouth syndrome. Infants no honey until after they are 12 months of age due to infantile botulism. No whole milk until 12 months of age for a wide variety of reasons. Low iron, zinc, low C content. It's not easy to digest. It has a high renal solute. So we don't want to give that to them until they're after 12 months of age. Feeding. Babies don't have a mature swallow ability until they're 4 months of 4 months of age. So no solid foods until then. 4 to 6 months of age, here they have an insufficient amount of pancreatic enzymes. And this is the enzyme amylase specifically, and that's the enzyme that initially digests carbohydrates. So being able to sit unsupported in a high chair is something that can indicate readiness to eat solid foods. During the first 6 months, a baby should not have more than usually 32 ounces if you are feeding formula during a 24-hour period. The first month in general, babies eat every 2 to 3 hours, 2 to 3 ounces, and then about 2 to 4 months, it's every 3 to 4 hours, 3 to 4 ounces, and then at 4 to 6 months, it's roughly 100 milliliters per kilo in a 24-hour period, roughly 4 to 5 ounces, 4 or more times a day. They can begin eating iron fortified cereal because typically it has a very low allergen potential, and they will get that until they are at least 18 months of age. An infant who is exclusively breastfed will be given iron supplementation at 4 months of age. Extra fluids are not required before 4 months of age because this can actually cause water intoxication. If the mom is vegan and breastfeeding, you need to take note of the vitamin D and vitamin B12. That might be necessary if the mom is vegan. So note, put food on the back of the tongue when you're feeding, starting to feed solid foods. You also want to feed the solid foods when they are hungry before you formula feed them or breastfeed them. Because if they're not hungry, they're not going to take the solid food. You want to start with 1 to 2 teaspoons, increasing to 2 to 3 tablespoons of feeding. You want to give one food every 4 to 7 days to monitor for allergies. We don't want to introduce foods by mixing them in the formula or the bottle. We want them to appreciate the taste and texture of different foods. Iron fortified cereal should be given daily until they are 18 months of age, as I mentioned before. So feeding during the first year, birth to 6 months, we already mentioned breastfeeding or formula feeding. And then here we've got 4 to 12 months. Here we talked about adding solid foods 4 to 6 months. Usually the first food outside of the iron fortified rice cereal is typically strained, pureed, or finely mashed. Finger foods such as teething rings, raw fruits and vegetables can be introduced between 6 and 7 months of age. You want to make sure chopped table food or commercially prepared junior foods can be started by 9 to 12 months of age. With the exception of cereal, typically the order of introducing food is variable. Often they will introduce fruit, then vegetables, and then meat. But some practitioners will introduce vegetables first, because if you introduce fruit first, then they may not want to eat the vegetables because the fruit is sweet. You do want to introduce one food at a time, as I mentioned already, usually at intervals of 4 to 7 days. You want to introduce solids when they are hungry. Begin spoon feeding by pushing the food to the back of the tongue, because the natural tendency is to thrust the tongue forward and thus spitting the food out. You want to use a small spoon with a straight handle, and as I mentioned already, begin with 1 to 2 teaspoons and then gradually increase. As the quantity of solids increase, you're going to be decreasing the quantity of milk to prevent overfeeding. Typically, we want to limit formula or milk to about 32 ounces daily, and then fruit juices to less than 6 ounces daily. Never introduce foods by mixing them with the formula in the bottle. Parents typically can discontinue supplemental iron once iron fortified cereal is given. So fruits and vegetables here, we're going to start these at 6 to 8 months of age. Applesauce, bananas, and pears are typically well tolerated. You want to avoid anything that is in a can that's not specifically designed for infants because of the possible lead content and then the addition of salt, sugar, or preservatives. Only offer fruit juices from a cup. We don't want to put it in a bottle because of cavities. And again, here, 4 ounces per day or less. Children really don't need juice. Meat, fish, and poultry. Here, this is 8 to 10 months when we're going to start. You want to avoid fatty foods. You want to prepare by baking, broiling, steaming, or poaching, including organ meats like liver, because these have high iron, of high vitamin A and vitamin B complex, so these are good for them. If you're going to be giving them soup, again, you want to make sure it's something they've already had, because you don't want them to have a reaction and then there's 4 things that they've never had before. You want to avoid commercial meat and vegetable combinations because they typically have a low protein content. Eggs and cheese. Here you can start at about 12 months of age. You can serve the egg yolk hard boiled and mashed, or poached. You want to introduce egg whites in small quantities, more like at 12 months-ish, because this is something that is a high allergy potential. Cheese is actually a very good substitute for meat and can be used as a finger food. Foods that have high allergen potential are things like eggs, specifically the egg white, cow's milk, wheat, soy, and peanuts. So this concludes the presentation for Week 1 Objectives, Part B. Thank you and have a nice day.